Yeah, hello again. Now I'll be talking about movement disorder emergencies. This is a very interesting topic. In fact, because we'll be covering different type of pathology that you can be facing or encountering in your activity of daily practice. In fact, movement disorder usually very rarely require going to the emergency room or seeing a patient with an acute or subacute movement disorder. However, there are some of them, and I'm going to share with you in the next 20 minutes the different type of pathology that you can see as a movement disorder emergency in the emergency room or in the clinic. Before going into more detail, I would like to tell you something very important. Movement disorder usually are divided into two categories: the hypokinetic movement disorder and the hyperkinetic movement disorder. Hypokinetic movement disorder like Parkinson's disease, neuroleptic malignant syndrome, and others. Hyperkinetic movement disorder, where there is hyperactivity like chorea, Huntington disease, hemiplegismus, and others. We'll start with the hypokinetic disorders. We'll be covering three major topics: neuroleptic malignant syndrome, serotonin syndrome, and acute Parkinsonism. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome, it is the disease. Every time you have someone in the emergency room who is coming presenting with the combination of fever, rigidity, and change in mental status, he or she are guilty of having an NMS or neuroleptic malignant syndrome until you prove the opposite. In fact, because if you do recognize this disease early, if you took early in the disease, the chances of recovery are high. If you are delayed, it can be fatal. So neuroleptic malignant syndrome is the combination of fever, rigidity, and change in mental status. Usually, it's secondary to exposure to drugs that block the dopamine receptors. Most cases are caused by neuroleptics. They can be typical or atypical. Other medication that can be responsible for neuroleptic malignant syndrome is chlorpromazine and metoclopramide. It is very important to consider it as soon as possible. It's usually affect patient, young and middle-aged men are at higher risk. Like I have told you, it's the combination of fever, rigidity, change in mental status. They can have also autonomic dysfunction. They can have also other type of mood disorders such as tremor, dystonia, and myoclonus. In fact, to make the diagnosis of neuroleptic malignant syndrome, you need to have the following criteria: major fever, rigidity, and elevated CK, minor tachycardia, abnormal pressure, tachypnea, change in mental status, diaphoresis, and leukocytosis. The presence of all three major, or two major and four minor, indicate a high likelihood of neuroleptic malignant syndrome in the appropriate clinical context. In fact, regarding the treatment, there is no prospective randomized trial showing that which medicine help. However, I believe that bromocriptine is the drug of choice. You can also use dantrolene sodium. It's a non-specific muscle relaxant that reduces muscular rigidity and minimize the rhabdomyolysis. What I usually do, honestly, I combine both of them together, and it can work very well. Electroconvulsive therapy also has been reported to be successful in severe form. Like I have told you, combination can work well, and personally, I have tried several times and had good result. Whenever you start the treatment should be 7 to 10 days. And in fact, it depends on the half-life of the causative agent, but still it has to be given 7 to 10 days. Do not do the mistake of starting neuroleptic as soon as they are getting better. You have to wait at least 2 weeks after the NMS has cleared before putting them on the medicine. I do understand that this is a problem in patients who are having schizophrenia or they're agitated. However, you can try to manage those patients with benzodiazepine, but do not put them back on neuroleptic. The second symptom is serotonin syndrome. In fact, any drug that increases serotonin transmission can precipitate serotonin syndrome. Serotonin symptom had the following symptoms: fever, myoclonus, and change in mental status. There are many clinical features between neuroleptic malignant syndrome and serotonin syndrome. However, in serotonin syndrome, you will find more myoclonus, hyperreflexia, seizure, and mood alteration. Those are the medicine that have been reported to induce serotonin syndrome. You know, this is a big list: MAO inhibitor, SSRI, SNRI, tricyclic antidepressant, triptans, amphetamine, and cocaine. This is not to alarm you one more time. However, when you have someone with change in mental status, fever, myoclonus. I mean, check for this for the medication. If they are taking any of those medicine, it can be related to the medication, and then you can act accordingly. The treatment is like neuroleptic malignant syndrome. You have to stop the causative agent. Cyproheptadine has been shown in severe form to be useful. Usually we give 32 milligram. That's being divided into 4 or 5 doses. Serotonin syndrome can be either very benign and resolve it quickly, or unfortunately, sometimes it can be potentially fatal. The third type is acute Parkinsonism. I always teach my resident and fellow by telling them that Parkinson's disease is a progressive neurodegenerative disorder. Parkinson's disease is a progressive neurodegenerative disorder. In fact, it's true. However, unfortunately, sometimes when you see patients presenting with acute or subacute onset of Parkinsonism, this is completely different story. You have to look for something else. Okay, so any patient who presents with any acute, like sudden onset of Parkinsonism, or even a few days, no, this is not Parkinson's disease, this is something else. In fact, in this situation, the first thing that you have to do is to check for the medication list. And number two, you have to check for imaging of the brain. Go ahead for CT brain if it's in the emergency room, and afterward order an MRI. And do a full physical exam, trying to find any possible etiology that can help you in making the diagnosis. Those are the etiology of acute Parkinsonism: stroke, subdural hematoma, hydrocephalus, drug-induced mainly neuroleptics, anti-epileptics, chemotherapy agent, cordarone. Cordarone and anti-epileptic will induce more tremor than anything else. Any infectious etiology such as HIV, Whipple, or viral encephalitis, metabolic with the central protein myelinosis, toxic exposure, manganese, carbon disulfide, or cyanide. Sometimes also that can due to psychiatric disorders such as catatonia. This was the hypokinetic. What about the hyperkinetic of movement disorder? Those are the different type of hyperkinetic movement disorders. I know that Dr. Ashish earlier talked about them, but I'm just gonna go quickly over every one of them. Chorea, it's an involuntary, irregular, purposeless movement that flow into another in a random fashion. It's like dancing. Balismus is more rapid. It's large amplitude proximal movement. And I will be showing you some video, by the way, in a few minutes. Myoclonus is the sudden, brief, shock-like movement that can be due to muscle contraction, and it's called positive myoclonus, or loss of muscle tone, and it's called negative myoclonus. You have tics, which is paroxysmal movement or vocalization that can be seen in Tourette syndrome, or you can have dystonia. Dystonia is the only one that's a sustained muscle contraction. Everything else is temporary. However, dystonia is present the whole time. What are the etiology of hyperkinetic movement disorder? It can be classified into acquired due to vascular, inflammatory, tumor risk, or drug-induced, or it can be hereditary, such as Huntington disease. It can be also idiopathic, such as Tourette syndrome. We'll start first with the chorea. As I have said, chorea is an involuntary, irregular, purposeless movement that flow into one another in a random fashion. Chorea might be secondary to toxic, metabolic, vascular, or infectious etiology. One of the most common that you can be seeing, although it's becoming rare in our country, is Sydenham chorea. Sydenham chorea is a chorea that usually occur in children, almost never in adult. And it's a neurological manifestation, rheumatic fever. The incidence has drastically or dramatically decreased over the last few years because of the use of the penicillin. However, it can be still seen in certain area. Those patients will have a chorea associated with behavioral changes, weakness, and hypotonia. Usually, the symptoms occur 1 to 6 months after the streptococcal pharyngitis. They are sudden in onset. The diagnosis is made through the elevation of anti-streptolizine antibody. However, a negative anti-streptolizine antibody do not rule out the possibility of Sydenham chorea. The treatment is penicillin. Penicillin will prevent the cardiac complication of rheumatic fever, and sometimes can be used for over a few years. If the Sydenham chorea, if the chorea by itself is really bothering the patient, you can try carbamazepine or valproic acid. There have been some observational data mentioning that dopamine receptors, like antipsychotic or neuroleptic, or MAO inhibitor can sometimes help in the treatment of the chorea. Now I have two videos that I would like to show you. Video number 1. This is a patient or a child with a Sydenham chorea. You can see those jerky movement, like the dancing movement affecting the upper and lower extremity. This is video number 2. You see those choreoform movement. This is second video. This is also a patient presenting with Sydenham chorea. You see the movement of the tongue. Her head moving. She cannot sit still. Tongue again. Okay, we'll stop here.
And this crying and weeping is a part of rheumatic chorea. This is known as emotional liability. They keep on crying and sometimes they weep, they laugh. This is part of rheumatic chorea.
Okay, so this is typical. I mean, typical Sydenham chorea, and what he said at the end is right. I mean, it is part of the disease to cry. The second type of chorea is a chorea gravidum. It's usually occur in the first or early second trimester. It can be unilateral or bilateral. Dysarthria is common. However, fortunately, it disappears by the third trimester. So basically, those patients should be having a normal delivery. You will see it mainly in the ward, OBGYN ward. What also you have to look when you have someone presenting with chorea to think about antiphospholipid syndrome. And you have to check for antiphospholipid antibody because chorea can be the sign of systemic lupus. Another metabolic that you need to check, and in fact, you have to check it in every type of movement disorder, is hyperthyroidism. Always check for TSH, T4, and hyperglycemia. Those are the etiology of acute chorea. We have it can be vascular in origin, like ischemia, hemorrhagic stroke, cavernous angioma, or cerebral anoxia. We have the metabolic, hypoglycemia or hyperglycemia, hyperthyroidism, pregnancy. You can have a cerebral mass lesion or abnormality in the basal ganglia. It can be due to multiple sclerosis, sarcoidosis, and many infections. This is why when you have someone with chorea, you have to do a full workup before being able to make the diagnosis. Also keep in mind that oral contraceptive can induce chorea as well as levodopa, cocaine, amphetamine, and alcohol intoxication. Hemichorea hemibalismus, it's another type of hyperkinetic movement disorder. Those patients will have a large amplitude flanking movement of one side of the body. Usually, hemichorea hemibalismus is secondary to an ischemic stroke of the subthalamic nucleus. Most of the time, this is the case, or it's secondary to hyperglycemia. It's relatively rare. The annual incidence is 1 in 100,000. This is secondary to a population-based study from Belgrade, Serbia. Stroke being the most common cause, and only minority of the cases have lesion within the contralateral subthalamic nucleus. The second common cause, like I have mentioned to you, is non-ketotic hyperglycemia. Now I will be showing you, this is the MRI. As you can see on the MRI T1 weighted image, that there is an hyperactivity in the putamen, caudate nucleus, and the globus pallidus. You can see it here. And now I have a video that I'm showing to you. A patient with hemibalismus.
Monday afternoon, I just started gradually losing control of my right side of my body. And Tuesday, of course, it was worse. I mean, Tuesday, Wednesday, and today are all about the same.
Okay, so you can see this jerk, the movement that this patient was having. The third type is myoclonus. The difference between myoclonus and all what I have said about it, myoclonus is sudden onset. It's a jerky movement. It's like shock-like movement that can be due to muscle contraction, and it's called positive myoclonus, or loss of muscle tone, and it's called negative myoclonus or asterixis. You see it more often in the intensive care unit, especially those patients who are having toxic or metabolic disturbances, or they had some cerebral anoxia, secondary to cardiac arrest. We see a lot of them, honestly, in my practice. The etiology of the myoclonus can be seen in serotonin syndrome and neurotic malignant syndrome. It can be due to medication such as MAO inhibitor, SSRI, SNRI, tricyclic antidepressant. It can be also seen in gabapentin and triptan. If the patient is using any kind of cocaine or amphetamine, in patient with hepatic failure and renal failure, this is a common etiology for myoclonus. Cerebral anoxia, especially after cardiac arrest, this is where you see the patient, the MRI finding in patient with cerebral ataxia, anoxia, I'm sorry. This is a video to show you a myoclonus. This is a patient who had a cardiac arrest. And you see this jerky movement. It's a shock-like movement. This is typical myoclonus. Okay, we'll stop here. In fact, the chances of good recovery when you see myoclonus in patient with brain anoxia is extremely low. It's a very poor prognosis. There is an entity called Lance-Adams syndrome. This is a post-anoxic myoclonus that usually occur after an anoxic event. Those patients do not have any myoclonus during rest. However, during action, they have an action myoclonus. They have a myoclonic movement. Usually it resolves by itself. However, it takes many years before it goes away. The third type or the fourth type is tics. Motor tics are common in school children with a prevalence of between 4 and 9%. Usually the average onset of symptoms is between 5 to 7 years old, and most of them will disappear by puberty years. There is two reasons why those patients present to the emergency room. Either there's exacerbation of their movement, or they have a neurologic compromise secondary to tics. In fact, we know that tics, wax and wane, and it comes and goes. However, there are some factors such as physical or emotional factors or infectious or medication that can exacerbate them. So whenever you are having any patient presenting to you with exacerbation of their tics, make sure that they did not take any medicine, or they are not emotionally upset or sad, or that have any infection that can be behind the exacerbation of their symptoms. In the emergency room, as I have told you, you have to look for the potential exacerbating factor. In clinic, you can always, this can be done as an outpatient. You can treat those patients with neuroleptics or dopamine depleting agent. For patients who are having resistant form, and when it's focal, botulinum toxin injection can be done. Neurologic compromise can occur secondary to tics. It's very rare, extremely rare. However, in severe tics, you can have compressive neuropathy as well as cervical myelopathy. The last one is the acute dystonic reaction. Acute dystonia reaction is most commonly seen after exposure to dopamine receptor blocker, both neuroleptics and antiemetic. It usually occurs 24 hours after the exposure. And it is estimated that around 90% of the reaction will occur within 5 days. In fact, acute dystonia is less common than tardive dyskinesia, and dyskinesia is usually more frequent and it occurs in different settings. Usually it occurs in patients with Parkinson's disease or taking levodopa. Acute dystonia this is not the same, it's completely different. The clinical manifestation of dystonia can be diverse. It can affect the head and the neck. You can have also having laryngeal dystonia. Can have a blepharospasm where they have a closure of their eyes. They can have cervical dystonia, oculogyric crisis, and focal limb dystonia. All have been reported. A treatment is IV anticholinergic, such as benzotropine mesylate, or you can give them diphenhydramine, can also help. Because of the possibility of recurrence, you can give them short course of anticholinergic for 5 to 7 days. That can help a lot. Now, I would like to show you, first of all, this photo of patient with cervical dystonia. This is typical, or we can call it acute torticollis. And this is a video about dystonia. This is an acute dystonic reaction.
So, when did you start having trouble talking? Early this morning? And did you take any drugs? Other than your prescribed drugs? No? You don't do cocaine or anything like that? No? Okay. Count to 10 for me.
1, 2, 4.
You see this dystonia? I mean, he's unable
Okay,
to
that's
talk secondary to the muscle contraction.
That's what I want. Right.
You see significant difference between before and after Benadryl.
Quick question. Has the pupil on this eye, has it been bigger than the pupil on your other eye for a while?
Okay, we'll stop here. Now, last one is, or next hyperkinetic movement disorder is acute torticollis. Some people might say acute torticollis is like cervical dystonia. What's the difference? In fact, acute torticollis, it will happen one time and then it's over. Cervical dystonia is more long-term. It's a chronic disease. Acute non-traumatic torticollis usually occur in children more than an adult. And in fact, it's really an emergent, it's to consider to be a medical emergency. Those children, because whenever you are having children with acute torticollis, you have to look for posterior fossa tumor, cervical chordae tumor, and infection. Acute infectious torticollis may follow a number of infections, including pharyngitis, tonsillitis, mastoiditis, or other infection involving the head and the neck. It can be secondary to atlantorotatory subluxation. All the torticollis in general, and all what I have mentioned before, usually they occur before the age of 13. Usually on physical examination, you will find a painful fixed torticollis that occur following an infection or recent surgical procedure. It's very important that you recognize this entity and treat it as soon as possible. The initial management will be to treat the infection, cervical immobilization, and then you have to go to do the workup, including imaging of the brain and the neck as well. The treatment of the hyperkinetic movement disorder, this is kind of a resume about what I have told. For chorea, you can treat them with neuroleptic, such as haloperidol, risperidone. You can also use tetrabenazine, dopamine depleting agent. You can also use benzodiazepine. What I recommend is try always with tetrabenazine. It has very little side effect and it works well. For the myoclonus, valproic acid is the drug of choice in my opinion, but also you can use clonazepam and neuroleptics. Finally, for tics, I also use tetrabenazine. It works better. I have tendency to use clonidine. Afterward, I go into the neuroleptic. And finally, for the acute dystonic reaction, you can use benzotropine mesylate or diphenhydramine like we have saw it in the video. In conclusion, ortho movement disorder are often not regarded as an emergency. Here we have reviewed all the hyperkinetic and the hypokinetic movement disorder. You have to have a systemic approach. Always check for the medication list. Make sure that there is no exacerbating factor. Do not hesitate to do an imaging of the brain. Thank you. We'll get into the question now. My first question is, neuroptic malignant syndrome is secondary to neuroleptic, atypical neuroleptic, benzodiazepine, or metoclopramide. Choose the wrong answer. The second one, chorea gravidum occurred the first trimester, third trimester, or postpartum. Choose the right answer. The third question, workup for hyperkinetic movement disorder should include MRI of brain, blood workup including TSH, genetic testing, or all of the above.